Rai is a Regents Professor at Harkin's Chair in Information System at the Robinson College of Business at Georgia State University. Arun's expertise is in IT-enabled innovation and business value and IT-enabled governance in intra-organization relationships. Call upon Dr. Arun Rai and Dr. K. Ganapathy on the stage, please.
This is going to be a rather unique session in that we are coming to you with solid data. I always was concerned whether a few hundred people like us, who obviously we are all mad, otherwise we wouldn't be here, whether these mad people are trying to impose upon hundreds of thousands, millions of people, M-health, digital health, e-health, telehealth, etc., etc. What is it that the masses of India really want? Do they still want to hold a doctor's hands, or are they prepared to look at a doctor on a screen? Do we need to adopt behavioral modifications, if you want to call it, to convert them and try to convince them? So we need a baseline for this, and I'm very happy to have had a wonderful collaborator with Professor Arun Rai of Georgia State University. I think this is a great example of what collaboration can do. We consider Dr. Arun Rai.
Namaste. It's a real pleasure to be in Hyderabad. Thank you to the organizers and thank you to the audience for everything. I've just had a fantastic time in the hallway conversations and breakout conversations. I'll jump right into it. We're going to try to highlight for you in 10 minutes, which is always a challenge, the key findings of this study. To kick it off, the first question of any good study is, why bother doing it? And just because other people have not done it is likely the worst reason to do a study, because maybe they were very smart and chose not to do it. Our motivations were grounded in a simple statement made by Amartya Sen that quality of life is linked to citizens' capacity to use resources to function effectively. This naturally generalizes to healthcare. And when we look at what it takes to function effectively when it comes to accessing and using healthcare services today, I'll first focus on, and which become very important to consider. First, what is the willingness of people to use mHealth? Second, what is the present level of awareness of mHealth, and what is the present level of use of mHealth? A very important question to understand are the systematic disparities that exist in society when it comes to the use of mHealth. Now, given all of this, from a directional standpoint, an important question or set of questions that need to be also addressed is, what can we do, or what should we focus on with respect to designing solutions, building awareness, and promoting use? Moving on, in terms of the study, the procedure, I will not belabor it. Dr. Ganapathy has set the stage for it, but it involved cooperation across the globe, multiple parties across multiple institutions, and a passion to really try and get good scientific data through validly designed measurement instruments. And we ended up with 1,886 valid responses across urban and rural India. The sample characteristics itself, we have a good representation by age, as you can see, spanning from 18 to 22 to about 51 through 60, and a marginal group over 61. With education, we have about 38% of our respondents who were below the 12th grade in terms of education. We have about an evenly balanced panel in terms of gender representation, and we have a 69 urban, 31% rural representation in the sample, with a clear skew towards the urban population. But nonetheless, a significant sample size in both groups, if you will, for meaningful comparisons. From an income standpoint, you can see 46% of the sample reported less than 15,000 Indian rupees per month. In terms of other pertinent sample characteristics, given the objectives of the study, what's very striking from a health standpoint is that 35% of the respondents felt that they were either moderately healthy or unhealthy. That, folks, is striking. Equally striking is the fact that 54% of the respondents reported that they did not have a health checkup in the last year. 30% reported that they had not had a health checkup in the last 5 years. So while the rhetoric of preventive care is high, the reality stands in front of you with these numbers. Also, what's very interesting from the standpoint of mobile technologies, I know there's a broad sentiment and a rhetoric around access to mobile phones. Please note the data that 46% of the respondents in the urban sample reported access to smartphones, with that number being fairly impressive, 22% in the rural sample. What was surprising to us, however, is that across urban and rural, with about equal numbers, 57% of our respondents reported they actually shared their mobile phones. This is unique to India. Now, looking at the behavioral intention to use mHealth, this really speaks to whether people want to use mHealth or how strongly do they feel about using mHealth in the future. Very impressively, and this is good news for the mHealth proponents, is that 55% in both the rural and in the urban samples indicated a high disposition towards using mHealth. And you have the numbers about 25-27% being in between, and 14-18% being on the low motivation side or the low willingness side to use mHealth. What we also find is, in terms of people who had indicated that they had used mHealth at least once. Now, please qualify that when we are using the term users of mHealth, we are talking about people who have used mHealth at least once. We have 28% in our urban sample that indicated that they were users at least once, 17% in the rural sample. That's a strikingly high number for a rural sample. This could be use of an SMS to access some health information. The basic point is there is some use that has occurred. What is also very important to point out here is that there is a reasonable level of awareness, 44% and 31% of the remainder of the samples in each category, where people say we're aware, they just haven't migrated from awareness to use at this point. And what's also perhaps not surprising but useful to ground it in fact is that 51% of our rural sample had never heard of mHealth, that number being 28% and a lesser number in the urban sample. Now, a couple of other points I'd like to point out to you. We talk about mHealth and mobile phones and mobile services. When it comes to phone calls, there really isn't much of a disparity between urban and rural India. People use it in equal proportions. However, when it comes to SMS, I know people always provide common stories. There is a disparity, and in fact, there are 3 points of disparity. Number one, you have about 84% of the urban sample that indicates use of SMS, that number being 52%, so you got a 32% disparity factor, if you will, there. What's also important to note is a second point of disparity with respect to SMS, and that is conversion. People who are aware but haven't migrated towards use. And you notice that about 24% in the rural sample are aware of mHealth but haven't pushed forward towards use, that number being a smaller 7% for the urban sample. And then there are 22% in the rural sample who haven't heard of mHealth, of SMS for SMS use. Now let's push forward, if you will, to awareness and use in terms of more sophisticated services such as email and internet search. Here you notice that indeed there are 2 points of disparity between the urban and the rural samples. That's both in the level of use but also in the level of awareness. The level of use numbers are quite striking. 42% in the urban sample say they've used email, they use the mobile phone to access email, that number being 17% for the rural sample. And again, with respect to lack of awareness, 24% in the urban sample said that they did not know that the mobile phone could be used for email access, likely stacking up again with people who are using basic phones, not smartphones. 53% in the rural sample. Those numbers are strikingly similar, and I will not repeat them for the rural sample. Now, there are some very interesting disparities that exist, if you will, between urban and rural samples. And you can break these disparities into 3 big groups, 3 key groups: socioeconomic, education, and income. And you notice that a 2-to-1, 3-to-1 disparity exists. And what that really means is that for every one person in the rural sample with a college degree, you had 2 people in the urban sample with a college degree. Likewise, with an individual income greater than 15K per month, for every 1 person in the rural sample, you had 3 people in the urban sample. You also notice a fairly distinct disparity levels commensurate with socioeconomic status with access to mobile services and the utilization of mobile services. We also notice disparities, albeit of a lesser extent, with respect to healthcare access and utilization. Notice that in every case here, the urban sample has a clear advantage. Now, we also proceeded to look at group-wise comparisons between people who were using mobile phones, those that were aware of mobile phones but were not using them, and those that were unaware. And looking at the sample comparisons again, with respect to these same sets of disparities, what we find is that indeed these same sets of disparities persist, albeit to lesser extents, if you will, compared to the urban and rural sample, meaning that the aware were more advantaged than the unaware with respect to socioeconomic, mobile access and utilization, and healthcare access and utilization. Notice one simple point I'd like to make is that the people who are living closer to primary care centers and specialized care centers tend to be more aware of mHealth, likely because of the knowledge spillover effects being proximate to those types of healthcare facilities. You notice that again, the users relative to those that were aware but had not moved forward towards use, again report an advantage in the same 3 blocks of factors. Now, one thing I want to very quickly mention to you, in much of the discussion on disparities, we often talk about socioeconomic disparities. In the context of healthcare, we have broadened this discussion to healthcare access and utilization. But what our data strikingly shows that indeed the disparities with respect to mobile access and utilization are very persistent and there across these different groups. So the implications of all of this, we pushed forward and analyzed our data systematically to identify what can be done by respect to designing solutions, building awareness, and promoting use. First point is in terms of designing solutions and building awareness, our study clearly points to the fact that one shoe size does not fit all. What we have here is that it's very important to make a distinction between the advantage and the disadvantage with respect to the 3 sets of resources we talked about: socioeconomic, mobile technologies, and healthcare access. Males and females tend to be very different in their use, again, of mobile services for healthcare, and then the disposition towards healthcare, whether it's preventive or corrective, again, becomes a consideration. And the last point I'd like to make here is that when you look at not just designing these solutions, promoting these solutions, we identified 3 key factors amongst a range of them that we considered that are the big levers to move forward. The first is self-efficacy. That means, yes, provide people the knowledge and the tools and the resources so they can use it. Give them a feeling of empowerment. If they do not feel empowered by using mobile technologies, there will be no use. And the third one is extremely important, and that's trust. But trust in electronic medium for healthcare services. So that's our puzzle, if you will. Willingness is uniformly high across urbanites and ruralites. There are disparities in socioeconomic, basic, and internet mobility, healthcare access and utilization. It's very important to adopt a segmented approach to designing solutions and building awareness. And then in terms of developing use, there are 3 key levers to be manipulated and developed, and that is trust, self-efficacy, and empowerment. And in wrapping up, I of course want to acknowledge a whole range of participants that allowed us to reach this point. They're enumerated here. Tremendous cooperation by several people. And here we are. Sorry for running over a little bit, but that was years of work, and 10 minutes crashed into it.
So I had a couple of questions. The first one was, what are the states in which the study was carried out? The 5 states.
Sure. Good question.
And that we should take into account.
Reasonable by way of sample size, right? So at the end of the day, I don't want to get into statistical terminology, but at the end of the day, we have reasonable sample size to make meaningful comparisons. But our study has to be interpreted within the frame of the 5 states and the fact that we do have more representation from the urban side. But the differences are so striking across the samples that I think we are very confident that these findings are reasonable representations of what's going on out there. I mean, this is the type of thing that validation, revalidation through broader studies is always a good idea. As a scientist, I will always say that, right? I mean, that's always a good idea. But this is what we have found based on our study.
Okay, and just
To the best of my knowledge, in terms of a broad national
Not only in India, but even in the world.
We are talking about consumer devices being used for healthcare enablement. Is there, typically in the US, we have the mobility health standards and there are some safety concerns which are addressed. Is something happening in India?
I think, well, but people are aware of it, and we are right now there are groups of people in various societies and in the government who are right now collecting literature and identifying what is happening in the rest of the world. One observation which, sorry, please go ahead, please go ahead.
The only data which shows the improvement where urban was rural area was better than the urban area, where the conversion from awareness to users of the mobile health, if I read your data correctly. Is that correct?
No, in fact, there was no point where relative to the urban sample in terms of the three categories of resources that we looked at. The urban sample always has an advantage. So that's one point. Then we looked at the users versus those that were aware. That's got nothing to do with rural and urban. So the rural-urban disparities are there across all groups.
Okay. Why I ask, is that the only reason why people are not adopting the mobile health solutions, or there is something more to that?
Reasons are big reasons, but again, if you go back to my observations that you have socioeconomic, you also have healthcare access and utilization. You also have, from a technological standpoint, mobile access and utilization. That's just the set of resources. But then there are also beliefs that people have. I think it's one thing to look at resources, but go back to what I started my talk with, that Amartya Sen's point, that eventually people have to use these resources. And the use of resources comes down to what they believe about them. And the three big things we found in terms of beliefs, and this generalizes to urban and rural strongly. Self-efficacy, meaning, do I have the knowledge and confidence in using this tool? The second one is, do I have a feeling of empowerment? And the third one is, do I trust it? So we looked at a number of factors. So those are the resources, but these are the beliefs. So we got to bring the resources on the one hand and make them accessible. But that doesn't solve the problem. We have seen too many projects in technology where the assumption is if you build it, they will come. Very often you build it and they do not come. I can give you example after example of infrastructure investments worldwide, including India, where things have been invested, but people haven't used it. So from a use standpoint in promoting it, I would suggest focusing on those three key beliefs that we have identified, which is self-efficacy, trust, and empowerment.
One last comment. On background of two of your slides are incorrect. Just wanted to mention that.
The next speaker also.
I'm Dharmesh.
Every day. This is a partnership among NGOs and the Clinton Foundation. So there are a number of initiatives ranging from specific conditions to broader awareness campaigns from a health standpoint that are underway.
There are actually dozens of applications available commercially. You can watch an X-ray, CT, ultrasound, everything. So everything now is increasingly becoming available in a mobile platform.
Okay, thank you.
Yes, please.
Health-seeking behavior itself is different in rural and urban. So would it be appropriate to compare rural and urban vis-a-vis a common concept of health? That's one point. And the second is also, would it be okay to look at something of a disposition to mHealth, or would it also vary by the nature of specific services which are delivered through the mobile?
So the first one in terms of are our standards or objectives for healthcare is that certain, if we say that healthcare access is a human right, then my position would be yes. But everybody will make their own decision on that. The second one is in terms of differences in attitudes, are they different? Certainly, we are finding that. We are finding that there are differences in the beliefs that people have. They have differences in terms of the resources they have. So again, we have identified them. But what we are pointing out is, in spite of the differences, there are certain factors. The biggest levers across urban and rural are common in terms of promoting use. And those are the three ones. I will not repeat them, but yeah.
Yes, please.
Hi, my name is Umashankar. Any demographic based on age group of who the primary user is, because you have a shared mobile phone usage. So is the primary user belonging to the age of 18 to 30, 30 to 50? Any observations on that? Again, rural and urban.
Yeah, right now what we have done is we have done the urban-rural comparisons, and you're right that at the end of the day, as you start segmenting the groups more and more, if you look at people who do not share and are of a certain age group, there are going to be more nuanced differences that break out. And we have done those analyses, but for reasons of time, we are unable to present it. But that's a good point. But the point that I'm presenting here does generalize across these age groups, et cetera, when we're looking at it. Okay, so yes, there are differences, but the findings presented here are generalizable.
Sure. One other question, I just want to know if you have done that kind of study, is point has been centered around mother and child. And other awareness campaigns really have been on chronic illness like diabetes. Do you see any observation in these studies as to where the urban and the rural are seeking their health services into?
That's an aspect we specifically did not examine.
Okay, sure.
There's just one observation I would like to make. I personally am absolutely thrilled with the results. This was done between October 2012 and April 2013. Just a year prior to that, in October 2011, I carried out a study at IIT Madras, which I thought was the cream of the cream of the cream of Indian society. We gave a questionnaire to almost 900 people, most of them postgraduates, PhD scholars, and a few staff members and administrative staff. To my horror, I found that less than 4% of almost 900 respondents from IIT Madras had heard of the term mHealth as late as 2011. So to me, the message is clear that over the last 18 months, the way the awareness is being created, and probably if we repeat this study next year, we will find the figures have gone up. So that's number one. Awareness is increasing. Number two is, though in spite of the urban-rural disparity, I never expected 22% of rural India, I think it's about 650 which are sampled in rural India, which is not a very small number, to say that they have already they're aware that a mobile phone can be used as a healthcare delivery system. So to me, the general message is that Indians are not, they have no resistance. We will not have a major resistance to the deployment of technology, to the use of healthcare delivery through all these electronic media. It depends on how we package the product. So long as we package the product properly, make it customer friendly, user friendly, make it cost effective, and produce results, I think this is a great way to deliver healthcare.
Sure. Thank you.
I'll just make one quick, but the people who have a preventive approach towards health. This was striking. So if you look at the level of healthiness of people and whether they go for health checkups, it's the ones that go for health checkups more with a preventive disposition who have a disposition or a stronger disposition towards adoption.
Sure, I have an observation there. Precisely, that is people with a preventive disposition. The second part of it is people who care, who are caregivers in the house. So that is precisely where I want to get to. Because I would like to develop mobile applications that target a particular audience in the first wave. And I'm really interested in that answer, if they're looking at a preventive or as a caregiver. As a caregiver, I care for my child, a caregiver care for my parents, then I am not really sick, but I'm not really, the disposition is different for both scenarios.
Your point is very well taken.
Telugu or Gujarat, or is it okay to do it in English itself?
While we did not specifically pose that question to users, at the end of the day, people want to understand, find things easy that are accessible to them. And it would fit in with the idea where they can give more meaning to it. It will normally be in the local language. Yes. Thank you very much.
Continue to stay on the stage. Mr. Arun and Devashish Basu will be the chairperson for this session. Mr. Devashish is the partner and the leader for the Enterprise Intelligence and Analytic business with EY India. He leads EI and A business across all industry sectors for EY India, Middle East and Africa, and for EY Global Talent Hub. As senior executive, he has extensive experience and proven success in building and providing leadership to large global technology, software and IT services organizations. He was a global head of KPGM in the US, where he ran $1 billion business in technological integration for information, communication, and entertainment. He also ran several large global arrangements in which he also had the board of many Silicon Valley enterprises set up. And talking about Mr. Arun Rai, we've already told you about his expertise, but now he was a passionate boat rower at the Madras Boat Club, represented the junior national team, got a brown belt in karate. He was a neighbor of Dr. Pratap Reddy in his childhood, used to play a lot of hockey with Shobhana Kamaneni and chased down Diwali parachutes with Shobhana and Sangeeta Reddy. In fact, Dr. Reddy used to give 100 rupees to whoever would win the game. We leave you guessing who would win the game in your presence, sir. So may I please call upon Arun Rai and Debashish Basu again on the stage to be the chairperson. Manish Gupta and Kase Poon. Check.
We'll just segue into our session on big data, business analytics, and it goes by a number of different names. So we have a very exciting set of panelists here, and I'm going to pass it on to my co-chair, who will soon have a functional mic.
Hello.
Check.
It's almost there, the functional mic. There we go. Over to you.
Sangeeta, thank you, Ganapati, and everyone else. So this is a very interesting session, and we have a very diverse group of panelists here. So we'll go around the table and introduce. And what we want to do is, as each one goes, I'll just read out a short bio, and then, we could do that. That way, we have more time for the question and answer. So I'll start with Arnab Laha, Professor, PQM, IIM Ahmedabad, India. So he's talking on data analysis in healthcare management. Professor Laha is a member of the faculty of Indian Institute of Management, Ahmedabad. He has wide range interest in statistics and its application to various disciplines, and has published several research papers in national and international journals of repute. 2 of his papers have received the Best Paper Awards in 2 major conferences. He was featured among India's best business school professors by Business Today in 2006 and by Business India in 2012. Dr. Laha.
For inviting me for this session. So I will be talking on a theme which will be followed up by by the speakers who will be following me, and it is on the theme of data analytics and its particular applications to healthcare. Now I begin with the basic question that what is meant by data analytics? Now, data has been with us for quite some time, and in fact, if you really look at the work of Newton or Galileo, they were actually based on analysis of a fair amount of data. However, in the organizational context, data analytics is somewhat new. Though the movement for having data in management decision making started way back in about 1920s with the First World War and the usage of statistical usage of sampling inspection plans to weed out poor quality products, the subsequent usage of data analytics in various phases of businesses took a long time. In fact, data analytics as we know it today is a relatively recent phenomena, possibly about 2 decades old. The focus of data analytics is to extract information from the data and make it immediately useful for decision making. The rapid improvement in information technology and the processing power of computing has been the key driver in this effort. So data analytics is a pursuit of understanding the data to make decisions. The decisions may be management decision making, or it may be decisions in the field of healthcare, or it may be as exciting as decisions taken to sending a rocket to the moon or Mars. Now, if you look at data analytics in a broad framework, data analytics can be thought of as being decomposed into two parts. One being largely descriptive, basically answering the what. So, what is it that is happening right now? What is the uptake of mHealth? What is the uptake of eHealth? And so on. So, that is one aspect of the description. The other aspect of the description can also be that trying to see that what are the key variables that is affecting it. So, is it possible that factor X is contributing more to the adoption of mHealth compared to factor Y? The other way of looking at other usage of analytics is to be predictive. So, you can look at a particular patient, you can have a system which will input most of the information that you have about the system, and the doctor would be the right person to do that, and then will the system may actually predict that whether a certain procedure would be useful for the patient or not. Now, that is an application of predictive analytics. So, when you are thinking of using eHealth or mHealth, predictive analytics will play a very, very important role, because it will give a specific signal, a very, very important signal in terms of saving lives, is to say the patient or the care provider that please refer him to a tertiary facility. Please refer this patient to a tertiary facility for saving the patient's life or having bad outcomes. So, predictive analytics is the key in this field. Now, healthcare sector, if you think of it, is made up of various participants. The pharmaceutical companies are a big participants. The managed healthcare, the healthcare insurance industry is another big participant. The biotechnology firms is a big participant. Medical equipments, manufacturers, devices, suppliers, these are a big participant in this healthcare sector. And finally, the healthcare facilities, without which we cannot exist, the hospitals, the healthcare centers, and so on. Now, to illustrate the usage of analytics, since this is an introduction to data analytics in healthcare, I will take up a couple of questions and try to see how an analytical approach may help in solving these questions. So, one of the questions that a pharmaceutical company would be interested in is that if you have two molecules or two treatment procedures, I am generically calling them A or B, which one of them is more effective in treating an ailment? Now, one of the ways of doing it is to do clinical trials. So, you have a double-blind clinical trial. Now, what is meant by double-blind is neither the patient knows, neither the doctor knows what treatment is being given to the patient. So, you have two treatments A and B. To one set of randomly chosen patients, you give treatment A, the other set you give treatment B, and then use the statistical methods that are available to compare between them. There are deep issues involved in it. There's a lot of research in this field which allows you to conclude that which is the better treatment. There are ethical issues involved because some of the treatments being new, there may not be enough evidence of their safety. So, you need to have procedures which will tell you that, well, this is the time to stop, either because you have a demonstrated positive effect or you are sort of getting worried that the effect is negative. Another application would be, if you are looking at the marketing arm of the pharmaceutical companies, is to target their marketing budget. Now, if you have, say, comparable treatments, as in many cases you have in particularly treatment of coronary artery diseases, where there may be a choice of surgery over medicine with equal efficacy. Now, if you have such a choice, then one thing that would be interesting for the pharmaceutical company is to figure out which are the doctors whom you should be targeting if you are selling a surgical product. Now, if you are targeting those who prefer medicine over surgery, this may not be the right way of utilizing your marketing budget. So, identifying and using those doctors who are more inclined towards surgery would be the ones that you will go for. In the case of health insurance, one of the important questions to ask is that if I am sort of thinking of making packages and sort of setting of admissible charges, then what is the appropriate amount of charges that needs to be reimbursed? Now, that's a critical question from both sides, both for the hospital as well as the insurance company, because if this charge is set to be too low, the good hospitals will not allow these patients to get admitted or for usage of the facilities. Similarly, so which will have a roll-on effect in terms of attrition of the customers of the insurance company, the health insurance company. Another key area that analytics is addressing and will address more in future is to identify and understand in advance, say, what kind of devices will be required by the hospital. So, the hospital at present may be in a certain locality, has a demographic pool, and you know that it has a certain set of instruments which it uses. So, what would be the next instrument that this hospital would buy? Now, if you can predict that, then possibly you can come up with arrangements with the hospital which will allow the hospital to buy this instrument seamlessly without much financial pain, as it can possibly have various kinds of financing contracts. And medical devices, some of them can be very, very expensive. In terms of healthcare facilities, one of the early applications of simulation had been to understand some critical concepts like what would be the number of seats that you should have in your intensive care unit. Now, if you are having more seats than required, you are actually taking up a whole lot of costs. Whereas if you are having lesser number of seats, you may actually not be able to provide all the patients with that number of seats and endangering their lives. So again, there is a cost-benefit trade-off, and analytics can play a very important role in identifying and helping out with such decisions. And finally, one of the key things that is nowadays being demanded by the patients is the facilities that the patient party also gets. So not only the patient is important, but the patient party is equally important. So understanding the needs of the patient party can also be used in decision making, and that can also be captured using the analytics. In summary, data analytics can provide us with better understanding of the patient and healthcare service provider needs. It can help in improving service delivery. It can help in improving the product quality, generating more value for organizations, and thereby reduce cost, improve the quality of service, and provide competitive advantage to the organizations.
Of data analytics from I think, professor's point of view and some of the basics that he had gone through. As I said, we have a diverse set of presentation, and what I would be taking you through a journey where how analytics can improve business performance. And organizing issue, my deck has not come here, the latest one. So what we'll do is we'll just switch the presentation. So I'll have my next speaker speak, and then I come back after him.
These things happen with big data, by the way. So Asia Pacific Oracle from Bangalore, India. Vinod is Senior Director at Oracle, currently managing Asia Pacific Applications sales team based in Bangalore. Vinod has strong sales and management experience spanning 19 years. He has 14 years with Oracle. He graduated from BTech with a degree in agricultural engineering, and we're looking forward to hearing his insights.
Thank you, everyone, and good morning. Welcome to the session. What I thought probably I'll do in this short session is try and give you a glimpse from a business perspective of what is driving the thoughts and design concepts for us as an IT organization. We spend about close to $5 billion in research, and I want to sort of give you 2 or 3 ideas, design concepts that we're using to build analytic solutions, and then translate that back to how it impacts the healthcare industry, how it's affecting the healthcare industry. If you look at decision making as a concept, all of us business leaders, we make decisions day in, day out. Some of the decisions are quick and fast. Some of the decisions we take a lot of time to sort of analyze, look at different scenarios, look for predictive data, look for data mining stuff, and then make decisions. Now, fundamentally, when you look at this, 2 big differences in this approaches. One is a lot of decisions are intuitive for us. It just comes like that in a click. That's because we are familiar with the territory. We have probably done that for years, and we call it our core area of expertise. And when we are forced to take decisions which are slightly outside of that core area of expertise, then we look for data, right? We look for information. We look for connecting to people and gather probably a completely different view than ours before actually deciding, hey, what is that 1 or 2 things that can help me make the decision. And in that whole process, what we are fundamentally trying to do is simplifying the complex set of data that's sort of presented to us and make a decision based on 1, 2, or 3 fundamentally key important issues, like probably which country do I invest more in terms of healthcare facilities, where is more ROI, right? So it could be either of these 2, intuitive decisions versus non-intuitive, and that's where a whole lot of data analytics comes in play. So that's the first concept, right? Let's move on. If you're looking at, again, some of the decisions that we make and the challenges associated with that, traditionally, what we used to look was always backward. Now, we actually look at a whole lot of data and a lot of questions that are running in our head. I mean, probably simple things like, do you know, is there an issue happening at Hyderabad? How much time will it take for me to get from here to the airport? So the questions are in our head, and we look for some data points or a whole set of data at the back end to throw answers back to us. In typical business kind of scenarios, it allows us to make decisions and also gives us focus, where to sort of look for more depth of information, where to sort of carpet bombing is probably good enough. So that gives us focus. Now, if you're looking at industries like healthcare, or a lot of transformational stuff that's happening is around a whole bunch of data that's available, but we don't know what questions to ask on that. In healthcare specifically, I'm referring to things like stuff that's happening on big data around genomics, around DNA kind of data, and a whole lot of research institutions across the globe are spending huge amount of time and effort in their labs to figure out, hey, we've got this huge set of data, what kind of patterns does it show us, right? And as human beings, it's quite simple. As a human being, you always want to get some patterns. You look at a cloud and say, hey, it looks like something, right? Now, is that in your head, or is it really something out there? We don't know, right? So the reasoning that always goes in our head is how do we build pattern out of a huge stack of data, especially on, let's say, the genomics and DNA kind of cases in this side. So if you're looking at what is giving us results from that is the fundamental ability to innovate. Look for questions that are unknown to us and look for answers probably which we never thought in our mind. One area could impact the other kind of stuff. Yeah. So that's the second one. So the first one was ability to make the complex simple, and the second one is marrying a whole lot of intelligence or analytics to a lot of data discovery. And both these are technologies and tools that we are developing at the back end. We own a whole lot of IP around both of this. The third is, how do you actually get deeper insights in terms of the data that's available to you, right? And probably, let's take an example of tumor. If you look at a tumor, all of us know that there is stage 1, stage 2, 3, and 4 stages of tumor. Stage 1 is probably really small, not really worried about, and stage 4 is where it gets really critical. If you look at just, let's say, the structured data, it may tell you things like, stage 1 tumor detection is like on the rapid increase. Probably it's 10 times, 20 times what was visible to us, let's say, a year or 2 years back. But does that tell you everything? Probably not, because I mean, the medical technology has advanced so much that even traces of tumor is very easy to detect at this point of time, which, a practiced professional doctor may not be able to identify under normal circumstances. But does that mean that, hey, I mean, is there really a problem with that population? Probably not yet, because some of these tumors may actually be, controlled by natural immunity that we have. So there's a whole lot of data that's available in unstructured environments, like research papers, thesis. I mean, today you talk about Facebooks and Twitters of the world, and there's a whole lot of data that's available there. So can we actually present both these sets of data points, one from the structured world, one from the unstructured world, to the decision maker, so that, hey, you can look at both of that and start making, more genuine, more informed decisions. Probably the fourth aspect also driving is the amount of personalization that you drive on top, right? What I mean by that is, today if you look at any technology, we always talk about a whole lot of personalization. So if you go to, let's say, Google, it presents to you data that you want to see, right? Because it has sort of not tracked whatever searches you have done in the past. But hey, today, we still love newspapers and books because it presents to us data that they want to tell us, not what we want to hear, right? And as a creative mind, which probably a whole lot of healthcare professionals are doing today, is actually looking at both these set of data points. And they want a mix and variety of structured stuff that's coming to them versus unstructured data that's coming to them, and which allows them to do deeper insights, both personalized as well as unpersonalized. I mean, if you only had, let's say, personalized information coming and you only thought in one direction, probably we would have had really fast horses today. We never would have had automobiles, right? So the four things, I'm just summarizing the four things that we are really keen in terms of design concepts at the back end in our labs when we are looking at analytics is: one, make the complex simple. Number two, build a balance between structured and unstructured data. Third, build a balance between the business intelligence or analytics versus data discovery. And fourth, how do you actually balance personalizations? These are the four concepts that are driving a lot of analytic concepts at the back of our minds. Okay, let's step into healthcare. I know Professor sort of touched upon this. Yeah, I mean, the healthcare industry is quite complex, right? And what does that mean from an analytics perspective? Excuse me, is the data structures and the lexicons and the terminologies used by institutions, organizations, and individuals in terms of capturing and storing data across these businesses are varied. What you do in discovery and research in terms of pulling up genomic data, how do you translate that back to a clinical research, right? And from a clinical research, if you're actually looking at healthcare, the healthcare delivery as a segment, the patient data from there, how do you de-identify that and aggregate that back into your clinical trials for analysis? So the complexity involved at the back end of a traditional healthcare value chain is phenomenally complex. The other end of the spectrum is organizations like government bodies, departments of health. How are they actually facilitating a whole lot of data standardization across the value chain where the interlinkages is perfect? It allows for multiplying innovation, it fosters innovation, and at the same time provides the level of ethical standards that's required to protect personal identities. So these challenges is driving the convergence of healthcare industry, the way we see it, to drive a whole lot of life sciences business concept and a whole lot of healthcare business concept converging together to give a whole lot of personalized stuff for individuals, which is also a lot predictive. It's also a lot preventive. And when we are looking at delivering care to your customers, which is basically patients, in terms of in a tender loving caring way, right? What are you trying to do at the end of it? You're basically hiding or trying to hide the whole complexity of delivering that at the back end, which is starting from drug discovery all the way to actually running, let's say, a hospital chain, which involves a lot of logistics, training doctors as well as paramedics, the equipments that go behind it. You're trying to hide all that complexity at the back end, and with a tender loving smiling face say, don't worry, you'll be fine, right? So that is the same concepts that's driving our research at the back end in terms of delivering analytics. We actually own the whole IT stack, starting from hardware, storage, all the way to business applications and analytics. And what we try to do is, hey, bring in the concepts of healthcare as an industry. We understand it more than anybody else, and our commitment is to deliver and enable technologies to the whole range of healthcare industry in a manner that helps to drive down cost, give personalized medication, and ensure that the whole society becomes a safer place to live in. Thank you.
So my presentation will give perspective on how the top hospitals in US has adopted data analytics. So I'll start with one of the famous presentation from the Cleveland Clinic CIO. That was a keynote presentation at the HIMSS 3 years ago. And from there, I'll talk about what would be the best ecosystem that can have on a performance analytics. So I'll give a CIO perspective from the large hospitals, global. Then I would come to talk about how you could build the best ecosystem possible, theoretically, and then how you have done practical implementation. We'll talk about a couple of case studies from two most wide hospitals in the United States, how they have achieved the number and increase of revenue by implementing certain data analytics program. So since the time is limited, I will be talking about the results. I'll also describe, how they achieved it at a large extent. So if you look at this slide, this diagram I had copied from the CIO of Cleveland Clinic's presentation. Most of the hospitals go through this journey. So first they bring a functional systems, then they put a lot of siloed information, even with the EMRs and EHR, and then start to put enterprise data warehouse and see enterprise intelligence coming. If you look at large group of hospitals which grew by acquisitions, etc., they start to very quickly feel, are we improving performance? Are we finding the bottlenecks, the inefficiencies in the system? Are we looking at the visibility that we need across all silos? Are we getting it real time? Forget the predictive or prospective analytics, and what's the journey? So if you look at the right-hand side of my slide, so hospitals in the range from 400 to 800 hospital, started fighting this battle. And a group of CIOs was called the Special Focus Group to HIMSS in 2009, July 8, and they were asked to come back with their perspective, and I summarized that without quoting them. What are your alternatives to start a journey for 3 to 5 years and push the best data analytics or performance analytics system? So if you look at this, what they started doing, the CIOs of these mid-range hospitals sat down and looked at two options. One, they can go to McKesson, Siemens, Cerner, GE, Eclipse, and Epic, and they can get this point transactional systems to just build the OLAP, and then they have decisions in the hand. They can also go to technology vendor, Oracle, and I really talked normally about the BEA part of Oracle, Cognos, SAP Business Object, Hyperion, ClickTech, SAS, or Microsoft, and that the internal IT build it up, what they need. Now, if you look at the pros and cons, obviously that's very costly to implement, maintain if you go by the second route. Now, once you go to the pure healthcare performance analytics companies. So people started looking at in the United States, who are the pure play analytics companies that they don't have to customize. They can come up with key performance indicators, literally drop on a platform and make that thing work on a dashboard. Can get the alerts, alarm notification on the pager, can get recommendations coming on the fly on the systems or any devices. And there are companies there, they are looked at, and there's one called Media Analytics. There are companies like Craneware, and I talked about, and they had interviewed some of these CEOs and CIOs, and still they come back with these 4 bullets that I see. Yes, there are guys who provide subscription-based solution, but technology may not be leading edge. So they may not get true correlation, true real-time information. And they're usually still retrospective, where they need a cutting-edge technology, and since this is about emerging technology, they don't give that perspective. So the industry still lack today the agile and most affordable healthcare-specific performance management solutions using the data analytics. I want to talk about the inefficiency and lack of visibility. Now, this has been a typical phenomena where even in the most sophisticated US hospitals, in general, see this problem. Now, housekeeping staff finds out discharged patient by checking a handwritten logs. Patients are being sent to other hospitals, and this is a factor called diversions. It's a major KPI the CEOs always deal with and worry about. We can't find rooms. We're having difficulties in tracking quality of care. Obviously, CMS being a big thing for incentives, there it has been more, and then I wanted to talk about how it applies to India's patient safety. So this has been a big thing, that our CMS scores are low, and this is especially the government hospitals are dealing with it. We are not getting full reimbursements. My surgeries are getting cancelled, and then want of an outpatient, inpatient bed. So the inpatient conversions become important. So someone comes in an outpatient, and how quickly the person can come for a surgery, something inpatient, from emergency to inpatient conversions. So the root cause they analyzed, they found a couple of the top ones that I have here. One is limited capacity intelligence. So do we have the best capacity management analytics solution in place today on top of my EMRs and EHRs and other transactional systems that I can get that knowledge proactively so I know when the bed is empty before it gets empty? Delayed discharges. In the United States, large hospitals spend millions of dollars to find that one KPI and fight that battle with ALOS, average length of stay, which is to do with the bed turns. And this has been almost epidemic, and then they're trying, the large vendors trying to solve the problem, people have custom solutions. So if you look at delayed discharge, it could be unmonitored bed turnaround, could be delayed visibility of empty bed, unseen capacity. So this hospital that I'm talking in the case study in a minute, they found that the emergency didn't know there's a transportation delays 5 times in a month has caused the delay in discharging patient. There is someone who didn't know how to operate a fax machine and a scanning machine, and that is why, and nobody knew that the machine has to be replaced, and that caused delayed discharge. And they put a system in place that got visibility across 4 different systems coming in together, and then ability to give that display almost on a real-time basis. If you look at the news, the state of New York cut medical reimbursement to hospital by 8%, and for a mid-sized hospital, this is an impact of $20 million revenue loss there. And the only way for hospitals deal with this cut is to be a lot more efficient with their services and use the technologies that is analytics and performance analytics along with their transactional system to deal with this. So now, if you look at this, the problem is hospitals invested a lot of money in putting softwares and point solutions in technologies on HIS, ADT, which is admission, discharge, transfer, radiology, order entry, bed management, pharmacies. But then how do you get all of this collated, and then have a drill down visibility using tools we talked about, Cognos and others, and then do the real-time root cause analysis and do prediction. Arnav talked about prediction. Now, globally, there are a lot of different algorithms used for prediction, and there has been used either in custom software or has been used in different ways. Now, I am going to present to you, lack of time, a complete map how an ideal system could look like on a performance analytics. Now, I have to go very fast on this. I just want to talk about these 5 areas. On the operation side, you could have 200, 300 key performance indicators that you can put in a dashboard and measure, and you prioritize. So the way to do it is come back with a 10 to 20 prioritized KPIs, and then you find a platform where you can enable, and then you can change it literally anytime you want. So here I talk about patient flow management. I also talk about hospital process monitor. There are a lot. On the care quality management, there are a lot of metrics. Compliance management, I wanted to talk a lot about MFU and then connect that with the patient safety that we discussed. And capacity management, where you are maximizing resource utilization of bed, the facilities, the doctors, nurses, and other ancillary systems. I will probably later on, if you're interested, I can talk about certain systems that does and certain processes and case studies which has many of the capacity management examples. The interesting thing is there is no correlation still. So how do you know an operational bottleneck cause your revenue increase or a cost reduction? Can you create a correlated system in an ideal hospital performance management where operations, capacity, compliance, any bottleneck can have a direct correlation with the finance? Now, there is a monitor called Meaningful Use Monitor. US is going through this journey of 3 stages of meaningful use, and there are monitors that you could use in analytics where you can track those. My thought has been in the patient safety declaration that we had gone through yesterday. You can talk about, let's say, for example, the point number 6 that I read, where hospitals will collect rates for the following patient safety indices, like patient falls, patient ulcer, needle stick injury. We should be able to get those measures monitored, and then what we could do is to have programs where you can either incentivize the hospital or you could take penalty based on threshold violated on this. And exactly the way the large US hospital today measures the MFU on a real-time basis so that they can get those incentives from CMS, from the insurance companies and the bodies, they can track the penalties. We could do the same thing in India here for the patient safety. I want to conclude it quickly with a couple of, so this slide is part of a white paper that exists in Veloz and MQ today, which is the company that I ran globally. After I left KPMG, it founded with several partners of Big Four. And if you look at that, CXOs are looking for ways to increase patient throughput. Now, if you look at roadmap to improve bed utilization, you optimize latency by getting the time reduced between occupancy and discharge. And I'm giving you an example here. If you look at a 400-bed hospital, the statistics goes like this in the white paper. 10 bed turn increase in a year is an increase of a $14 million revenue increase. So if you look at New York Presby, if you look at several hospitals, and the hospital I'm talking about in is Brooklyn called Maimonides, it's a 1,000-bed hospital, and the CIO has been named 3 times, HIMSS as the most weird hospital. So we came up with this result where we say that saving just 2 hours between discharge to admission can lead to an extra capacity of 6 bed days, which is increase of 1 bed turn. And now you could relate the 10 bed turn that does 14 million. Before I conclude, I just wanted to talk about another statistics, and this is my last slide, where you see the performance improvement. You see the way this hospital used a semantic-based correlation engine and then the state-of-the-art performance analytics. And that does improve the bed turnaround time, which is 20% reduction in bed assignment, about 30% reduction in bed occupancy, and this is 4 years data collected. We didn't have pure big data way of collecting data, but we had huge amount of data that collected, put in a large data warehouse, correlated, use this performance analytics real-time solution to do it. Look at the improvement they have in the occupancy and capacity. 10% improvement in bed occupancy. I talked about inpatient conversions, so that has been realized. And the nursing and clinical side, 40% reduction in outpatient. So these are achievable, and as we are going through a journey here, and I believe that we can get the data with big data and other technologies, correlate those in certain correlation engines, real-time present it, and also can even give information ahead of time predictively. So like in US, in a P4P, pay for performance, the nurse gets a page saying that, 5 minutes from a heart patient coming in the hospital, aspirin has to be administered. If not, you will get your score reduced. I think we need to go work to a society and get to that point. I know the journey ahead of you. Thank you so much.